Good afternoon, everybody. Welcome to our session. My name is Baby Rifona Nasution. I'm from Indonesia, and I'm a national coordinator for women living with HIV in Indonesia in National Network. And I'm living with HIV for 15 years and openly, and I'm healthy. I'm very proud of myself because my adherence on ARV. But this time, I'm not telling about myself because we have 6 excellent presenters will sharing their experience about confronting violence against women. I know this is for a long time become a problem with us, especially for women living with HIV. There is a lot of violence. And I will pass to my co-chair to introduce himself. Mr. Saidi, please.
Many thanks. Welcome also to this session. My name is Saidi Kapiga. I'm from the Mwanza Intervention Trials Unit in Mwanza, Tanzania, and also from the London School of Hygiene and Tropical Medicine. So I'm very pleased to see you all here. I thought I should just present a few slides before I introduce the first speaker to try and set up the scene. Yes. You know, intimate partner violence is a major problem, and we are all very pleased we have this session here. Globally, 1 in 3 women will have experienced intimate partner, which may be physical or sexual, with their partner or non-partner sexual violence. So it's a major problem, and obviously huge variations across the globe. You know, sub-Saharan Africa, where, you know, I come from, is one of the regions with the highest this. And these have huge impact, and that's why this session is devoted to looking at this. There are a lot of emotional and social problems with social well-being in women who experience this. But also, the reason why this is being discussed today is because it has huge potential impact of undermining women's efforts to prevent themselves from infection or to access services and treatment. This is a slide which summarizes some of the potential mechanisms in which violence may lead into increased risk of HIV and other STIs, ranging from potential biological factors, you know, including trauma, the immune, a lot of new studies coming and suggesting some impact on the immune response, to really the high-risk characteristics of perpetrators who perpetrate these tend to have higher risk of infection in general. But also, because of gender power imbalances, this may mean women are unable to negotiate for safer sex and others. It's not only the increased risk of infection, but also the potential to impact on reaching our goals of 90 or 90-87, 73, limiting access, but also reducing the possibility of essentially adhering to treatments. So we have very important goal to try to find a way we can prevent this, and we have 6 exciting presentations which will be able to show that some of the attempts to reduce this in different settings. So with that, I would like to introduce the first speaker, who is Dr. Maria Pantelek. She is a senior advisor on research and evaluation at the International AIDS Alliance, and she will be presenting on what do we know about interventions to prevent and reduce gender-based violence among young people living with most affected HIV in low and middle-income countries. This is a systematic review. Yeah, Maria.
Hi, everyone. I will present findings, very emerging new findings from a systematic review of interventions to reduce and prevent gender-based violence against young people living with HIV and affected by HIV. And I'm presenting this on behalf of a large group of researchers, one of whom is here, Madison, researchers at Oxford University, London School of Hygiene and Tropical Medicine, the Alliance, and elsewhere. So this research really came out from our adolescent programming, which is really, we're building a movement and a large group of adolescent treatment supporters who are helping other adolescents take treatment and informing them about SRHR. And one of the things that came out of this work was the young people and other partners, but particularly the young people who are leading on this work, have told us we need something to address the gender-based violence that we're subjected to. So we conducted the systematic review, and it's limited to low and middle income countries. So gender-based violence is associated with risk of HIV infection, as we've heard, but young women are at particular risk for gender-based violence, both gender-based violence and HIV. Gender-based violence is also associated with disrupted treatment for HIV. So it can impact kind of the health and long-term survival of these young women. And 28% of female adolescents and 29% of female youth in low and middle income countries have experienced gender-based violence in their lifetime. So the scope of this review was focused on adolescents and young people aged 10 to 24 who were either living with or affected by HIV. So we included also any key populations, where we're looking on studies with young key populations in low and middle income countries. In terms of types of interventions, we included anything that measured gender-based violence as an outcome, whether it was intimate partner violence or non-intimate partner violence, physical, sexual, emotional, or economic violence. We included studies that had comparison groups only, but those comparison groups could be either no intervention or treatment as usual, or a different intervention altogether. This was because we really wanted to kind of isolate the effects of the intervention. So I realized that in this presentation I will miss out a lot of what is being done on the ground and only present interventions that have been evidenced. And in terms of outcomes, we were looking at any gender-based violence, perpetration as well, and harmful gender norms. So I'm going to kind of skip through this, but overall we identified 3,056 studies through databases and 23 studies through other sources. And this ended in including 16 studies to the narrative review. And we've just done some preliminary meta-analysis as well. 13 studies were included in this because many of them had too much missing data. So we had 7 cluster randomized controlled trials, 2 randomized controlled trials, and 7 non-randomized studies. Most of the interventions targeted only young women. So 9 of the studies were targeting only young women. 1 was targeting only young men. 5 were targeting both sexes, and then 1 was for both boys and girls, but reported only on female outcomes. And overall, across these 16 studies, are represented over 21,000 adolescents and youth. Within South Africa, Uganda, Kenya, Ethiopia, Zimbabwe, and Brazil. So there are huge gaps. Those were the only countries that were covered. We didn't find any studies that worked specifically with young key populations or specifically with young adolescents living with HIV. All of these were with young people who were from HIV-affected communities or from HIV-affected households. So this is a huge gap, and just keep that in mind as I present. We found that baseline perpetration of gender-based violence among these young people ranged between 14.5% to as high as 59.8%. And baseline gender-based violence exposure or victimization ranged from 4.5% to 31.4%. This is something that's normally not kind of included in data extraction forms when you do systematic reviews, but I thought it was really important to look at to what extent young people were involved in this research. So 8 studies didn't report any youth involvement. It doesn't mean that it didn't happen, but they did not report any youth involvement in the study design, intervention design, or delivery. 2 of the studies involved young people for piloting questionnaires. Another 2 studies involved young people through consultations prior to the intervention design. Another 4 involved them in consultations during the intervention design, but only 1 really kind of reported proper involvement in intervention design. So this is shocking, but maybe not surprising. So all of the interventions, except for 1, were group-based and they were multi-component. They had many components to them, and that's why interpreting the meta-analysis that I will present later is a bit difficult. But most of them had multiple components. And the vast majority relied on different variations and components of using active discussions and knowledge acquisition with young people. Half of them were delivered in schools and half of them in the communities. But only 3 included community involvement. And remember, we were looking at attitudes as well. But only 3 studies we identified that had community involvement. So as you can see, the 4 studies were mostly psychoeducational. And of those 4, only 1 resulted in desired reductions in gender-based violence. 3 had kind of economic strengthening components, of which 1 reduced gender-based violence, 1 improved gender norms, and 1 resulted in increased gender-based violence. 3 studies were psychoeducational, but had an additional component of not just talking about gender-based violence and sex, but also including vocational skills. And all 3 of those resulted in reduced gender-based violence. And 6 interventions included self-defense or safer schools. And of these, 4 resulted in reductions in gender-based violence, and 1 improved gender norms, and 1 was ineffective. So these are the very preliminary results of the meta-analysis. We can't kind of infer too much from this, but what is important to see here is that the vast majority of interventions, when they're pulled together, we didn't find the desired effects. And there was too much kind of statistical heterogeneity. So there was too much inconsistency in terms of effects. Some were effective, some had mixed effects, and some were ineffective. We only found proper reductions in physical, intimate partner violence among young girls. There were just 2 studies. All other outcomes, we didn't find overall the desired effects. So in terms of conclusions, the interventions do not show large effects, if any. We found no effects on sexual violence or perpetration in the few studies that examined this. And the vast majority of these interventions focus on girls protecting themselves rather than on the wider community and people who are violating them. Most interventions further are psychoeducational, so there's a large assumption there that somehow by educating girls, people are going to violate them less. And we don't have any rigorous evaluations on what works for key populations, young key populations, and this is a huge gap. interventions were not co-designed with young people. We heard in the opening ceremony, and we hear over and over again, people are called on to engage young people in designing, in co-designing, and being meaningfully involved in the interventions that are supposed to help them. In terms of research gaps I've touched, we didn't find any studies with young key populations. We didn't find any studies specifically working with young people living with HIV. We found very few that involved and put the responsibility on the wider community. And studies are focusing on the experience of violence rather than on violence perpetration. And this is a quick thank you to our partners and funders. Thank you.
Thank you, Maria, for excellent presentation. So this is open for few questions or comments. Yes, number 2.
Hi. My name is Sylvia. I'm a woman living with HIV. I do a lot of work with women's network and community networks about as well violence, because it's such huge issues for us. And I'm just, thinking about research, evaluation, participation. Some of the themes that were I highlighted in the last participation for me is like, I just think that there is this paradigm in which randomized clinical trials are always the gold standard of research, and there is a paradigm in which researchers are on one side and us as community and young people are on the other as objects of research. And I'm just feeling like, how could projects integrate evaluation from the beginning, and how could we have frameworks that in which researchers and community work together from the very beginning of designing a project, designing what the success of the project will look like, and how we're going to look at its successes. And I'm sorry, but randomized clinical trials are not the only gold standards. We are researching very, very complex issues with very complex factors. And those kind of research, the randomized clinical trials, is designed to almost resolve a single question. Yeah. We need multidisciplinary studies, the meaningful involve the community from the very beginning. Otherwise, we're going to always end up not knowing what works.
Yeah, thank you, Sylvia. Can I address the question right away? So this review included studies that were both, they included both randomized studies and non-randomized, and none of them were clinical. So a lot of them they were either school-based or community-based. And so I think there are ways to do rigorous social science, interdisciplinary research in meaningful partnerships. And what that means is not just involving community, but as experts, because they have expertise that many researchers don't. And I think one of the big gaps is the fact that we're not even being held to account in academia. We're not even being held to, you can publish without ever mentioning how you consulted with the community, whether you even did it. And those who do mention it, they don't say how they did it and whether it was fair or proper. We need to involve community from setting the budgets so that they're also remunerated. And so we need to do a lot in terms of setting up those guidelines. But I do believe that communities, no matter where they are or no matter what the topic is, deserve the best available evidence to guide their interventions. Because if you were to intervene in young girls' lives in the UK, you would use that approach. So we can use that approach for key populations in low and middle income countries and young people as well.
Okay, can we have the next on mic 2? Yep.
Hi, Andrea Wirtz at Johns Hopkins. I was just thinking about the meta-analysis, and I was wondering if you could reflect on the measures that you observed which were used to measure gender-based violence, and if they were fairly consistent, or if you observed a lot of heterogeneity in the types of measures. And taking that the next step then, is it challenging then to pull it into a meta-analysis, or is it better to actually reflect on the individual findings if they are quite different measures? I think about recall periods. Sometimes it's based on certain perpetrators, et cetera.
Yeah. No, you're right, completely. and we didn't plan to do a meta-analysis. I think there was a lot of heterogeneity in measures, but there was also a lot of heterogeneity in the types of interventions that were delivered. So you cannot really infer a lot at this stage, but what the meta-analysis is helpful for is to show the overall lack of effectiveness, and I think that will hopefully push us to think more critically about the types of interventions that we implement and push us to invest more in rigorous evaluations as well, so that we don't just assume that things work. There are harmful, null, and mixed effects as well throughout these interventions. So that's what we were trying to get at, but we're still trying to figure out whether the meta-analysis is actually informative and useful.
Thank you, Maria. So we move on to the second presenter, who is Manuela Colombini. She's from the London School of Hygiene and Tropical Medicine. She's a social scientist with a background in health policy and systems analysis. The title of her presentation is Integrating Gender-Based Violence Screening and Support into HIV Counseling and Testing for Adolescent Girls and Young Women Assessing PrEP in South Africa and Tanzania. This is from the Empower study.
Thank you very much, and thank you for coming to the presentation. You took me by surprise. I thought I was the third presenter. I was still comfortable sitting. It's like, oh, I still have one. Okay, so good afternoon. What I'm going to describe today and talk about is a subcomponent on GBV screening of Empower study. And one of my colleagues, the PI, Sinead Delany, will present it tomorrow. So I'm going to actually just give you a very brief background of the issue, and just to add to what Dr. Saidi and the chair already said, and then just going into the description of the component, and then into the results. So, as also my previous colleague already mentioned, so adolescent girls and young women are highly vulnerable to HIV, with gender inequalities and violence as key factors in HIV acquisitions. And there is now, though limited, but still a body of evidence that shows that actually violence and gender norms might influence the treatment cascade, but what we can start to see from some of the results from trials and the demonstration project is also that these factors are also likely to influence PrEP uptake and use. And so there is actually a need for more evidence on how best to really strengthen adolescent girls and young women's agency to use oral PrEP effectively, while also reducing their vulnerability to GBV and stigma that could actually negatively influence the oral PrEP uptake and use. So what is then the Empower study? So the Empower study is an open-label demonstration project that it's evaluating the feasibility and acceptability of offering PrEP, oral PrEP, within a combination HIV prevention package for young women aged 16 to 24 in South Africa and in Tanzania. So, and one of the objectives are to really identify, counsel, and link to care young women attending HIV prevention services who may experience GBV, and also support them to effectively incorporate and sustain PrEP use within their sexual relationship. And we also offer, as part of the project, also community dialogue to actually mobilize the community support, and also some of the women, through randomized control trial, also might be offered clubs, so to actually empower them in sustaining in their PrEP uptake. So what I'm going to actually talk about is not the whole study, but just a subcomponent, the GBV screening that was integrated within HIV counseling and testing at baseline, and also at each of the follow-up visits throughout 6 months in Tanzania and up to 12 months in South Africa. So we developed this intervention package that integrated identification for gender-based violence, and we were looking at physical, emotional, sexual, and financial violence by partner, but also non-partners. among the young women. And we were also assessing their immediate risk of harm. And we were offering a safety plan and safety tips and linkage to care. And the GBV screening was based on 6 questions that were developed based on the WHO manual, clinical manual on gender-based violence, and they were actually conducted by counselors in South Africa and clinical nurses and clinicians in Tanzania. But I gave you away the study setting. So we actually conducted the study in 2 settings, in Tanzania and South Africa, which are sites with high prevalence of GBV and also risk of HIV and stigma, especially among adolescents. And so we conducted a qualitative process evaluation of the delivery of this subcomponent, and we assessed the GBV prevalence at baseline in all participants, and we conducted qualitative interviews with clinical staff, study staff, and also all participants. And we had students, primarily university students, participated in South Africa, and women who were working in food and alcohol outlets in Tanzania. And we conducted also 10 counseling session observations that primarily in South Africa, and also we took notes from debriefing sessions that were done with clinical staff on a regular basis to just assess the fidelity to the delivery of the intervention. And what we explored were issues around acceptability, feasibility of the delivery of the GBV screening, but also appropriateness of some of the referrals that were put in place. So just quickly, the reported GBV experience at baseline in the 2 countries. So 1/3 of the women experience GBV, lifetime GBV, and with the higher types experience were physical and sexual physical and emotional across both sides. And we had an incidence of 12%, which is similar per year, which is similar across some of the other IPV incidents in Eastern and Sub-Saharan Africa. And we only had 2 cases of who were in immediate danger of harm, but many of them, despite having experienced past abuse, still wanted to be referred for mental health and counseling. So they managed to access referral services and support services they might not have access if it wasn't for the study. So just going now into some of the qualitative data to really just give you a sense of the acceptability of the screening by the participants, by the young women. And there was the first time for all of them being asked actually about any experience of gender-based violence. And almost all found it really acceptable and amenable. So there was actually quite a strong value in sharing their feelings because, especially for the women who reported abuse, they actually lifted the burden from one's heart. And they see it as a positive thing for raising awareness, for recognizing there was somebody who was able to help them, and also challenge their traditional views, and many actually saw violence as part of a relationship. And for only a handful, that was a traumatic experience, especially if they were reliving some of the stories, especially with sexual abuse, and for some actually found it a bit too personal, and they didn't really want to share or trust the counselors, at least at the first encounter. So then moving on to the feasibility, so some of the facilitators that were mentioned, especially by the staff, were really around adolescent-friendly environment. So the whole issue about confidentiality, staff empathy, and absence of judgment, we actually are at the basic of delivering care for women who experience abuse. And also the familiarity with staff. So we have done repeated identification of violence throughout the study, and actually we saw that some women who didn't disclose at baseline actually disclosed afterwards, and mentioning that actually they trusted more and more the counselor, they would all see them, and so they actually gained their trust. And some of the issues that were mentioned by the staff also included, as a facilitator, the regular debriefing. So not taking cases back home really helped them also in some of the challenges that were mentioned around initial discomfort that they found asking women about violence very stressful as well. And some were also frustrated with the initial women law disclosure. And also to try and categorize some of the experiences that women were also telling them as emotional violence. And lastly, the safety plan, which was initially focusing a lot on the intimate partner violence, and actually we discovered that, well, with this group, most of them were not living with their partners and didn't really need an exit strategy, so we had to adjust and use additional safety tips. So the regular briefings really helped to actually support and face some of the challenges. And one of the enablers that were mentioned was having one on-site social worker, which was actually very helpful to link women immediately to care, though actually the external referral network was always not up to, I would say, there was a lot of interruption of services and often there was no follow-up. And the other issue lastly was kind of the limited awareness that some of the women would maybe disclose to the community workers, who were the first people who they met as part of the study, or the clinicians, and not to the counselors. So, and it's really taught us a lesson to really learn about training all staff, and not just the counselor who were offering the GBV screening, to be able to at least refer the women and make sure that they were empathetic and non-judgmental. So, just very briefly, we also asked the stakeholders, so the participants and the staff, also about their views on scaling up such screening also into routine HIV or PrEP services, and many were in favor and supported it. And but they foreseen still some systems barriers in public clinics, and particularly the limited referral that was in place, and also the time that was sometimes needed to counsel women, especially for the first session, and also the unfriendliness and judgmental staff present in some of the public clinic, blaming the young women for what happened to them, and also the lack of confidentiality. So in conclusion, 1/3 of our counsel women who participated in the study reported lifetime GBV, but the majority were not at immediate risk, but still needed referral for counseling or mental health services, even for past abuse. And the other key message that I want to leave with you today is also that integrating GBV responses is highly acceptable and feasible, but there are some principles that should be in place. And first of all is the empathetic listening and confidentiality. That should be a principle, like two principles to be respected. And also counseling should be adolescent-friendly and not judgmental, especially among this group of young women. And also the ability of the services to link people to support services, which is key. And also the staff support and supervision. We had debriefings, but it could be also informal supervision with another supervisor or etc. that could be put in place and should put in place, especially when there might be some vicarious trauma among the clinicians. So, and lastly, I want to acknowledge all the women and the study staff who participated and all the other partners that made the Empower study and its subcomponent possible. Thank you very much.
Any questions, comments from Manuela? Yes, mic number 2.
Hi, thank you so much for your study. It's fascinating. I had 2 kind of quick questions. I'm Sarah Malillo from IMA World Health. The first is, was the social worker position one that was normally part of the health system at the health facility? Just thinking about sort of scale. Mm-hmm. And the second one was around, you talked a bit about that piece on debriefing. Were the social workers able to talk to the clinicians who may have been experiencing their own violence? We know that there's lots of prevalence, so they too, it's like bringing up a lot of issues in their own lives, not just dealing with sort of what they're hearing, and what was sort of that piece like?
Thank you. Can I respond?
Yep.
So, yes, so the social worker was only present in South Africa, and that was part of the adolescent-friendly adolescent clinic that where we conducted the study. And I'm aware that not all primary health care clinics in South Africa has an on-site social worker, so that might be an issue, but it was really helpful, and the clinician, the counselor, all found it really critical to be able to link the people, and also because the social workers also had additional referral services where she may be referred the women, especially for long-term mental health issues. And the debriefings, well, the debriefings were a lot more on their challenges, so the challenges of the counselor and the clinicians and the nurses during the study. And sometimes that we touch issues around their emotional stress, but also what we did. We offer somebody, so we offer counseling that was actually done separately by somebody who was not directly involved with the study, and that seems to be very helpful. Thank you.
Thank you, Manuela. I don't see any other questions, so many thanks for your presentation. So the next presenter is Mary Muia from Kenya. She's a co-director of the National Organization of Peer Educators. She's a public health profession and expert in adolescents and young people's sexual and reproductive health. And she will be presenting the presentation titled Group Therapy for Gender-Based Violence, Reducing HIV and GBV Risk Among Adolescent Girls and Young Women in Nairobi Informal Settlements. Mary, welcome.
Thank you very much. Good afternoon, everyone. I want to depart from the first two presenters and not bring data to you, but promise to give you our program experience in Kenya, working with adolescent girls and young women in Nairobi's informal settlement. In terms of confronting GBV, our program experience focuses on group therapy for gender-based violence and how to reduce HIV and GBV risk among this population that we're working with, adolescent girls and young women aged 10 to 24 that live in Nairobi's informal settlements. I will quickly go through the background, describe what we've done, and pick a few lessons that we've come up with, and maybe conclude with what we think is our take-home message for all of you and for us to continue making impact with our communities. For those that have not been to Nairobi, I think Nairobi is in Kenya. We have a population of 3.9 million people in Nairobi city in 2015, but recently, I think in 2018, the population has grown to 4.4 million. In the settlement that I'm going to talk about, we currently are at 100,000, and it's a very small portion of land that carries a lot of families and households. And there we find adolescent girls and young women that require interventions. The background about GBV, I think nationally the first two presenters have alluded to that, but I'll go straight to Kenya and tell you that for every 5 people or women, 10 Kenyans have experienced gender-based violence. And these are women aged 15 to 49. And they will say that once in their lifetime, they have faced gender-based violence. We also know that the girls in the informal settlement have got very unique, vulnerable situations, and they're very vulnerable to HIV. We know that in terms of behavioral, social, and biological factors, these girls have got more risks when you compare to the boys or to the people that are within their age bracket. We also know that these girls engage in age-disparate and transactional sex. And of course, because of poverty in the informal settlements, there is a lot of unemployment, and this puts these girls into a very high risk of HIV. We also know, again, that perception that girls within the ages 10 to 24, we actually many times think that they can negotiate for safer sex, for monogamy, for condom use, and also we think that, or it's assumed that they can actually request their male sexual partners to be circumcised or to go for circumcision, which is not a reality in these informal settlements, as we found out in our project. USAID Kenya, East Africa funded Afya Jijini program, is one of the implementers of the DREAMS project, determined, resilient, empowered, AIDS-free, mentored, and safe intervention that focuses on adolescent girls and young women. We aim to empower adolescent girls and women to reduce their HIV risks and also ensure that while they live in the informal settlements, that they will come out stronger and able to exploit their potential. So within this project, the catchment zone is one of the slums like I spoke in Nairobi, and it has over 100,000 people. It's a very small portion of land, and it is in between a river, which we call Gong River. There is a westland, and there is also an industrial part of the Nairobi city. So we are saying that being a slum, there's also positive things about it, that we have very well-known footballers and DJs and artists that have been brought up in this particular informal settlement. So it's not just all bad for these girls, but there is hope also in that informal settlement. When we look at the way we were able to locate our girls and how to target them as a project, we did a girl roster mapping exercise, a technique, a programming technique that will take us from house to house, and we enroll and talk to the household, the one in charge of the household, and they will tell us how many girls live in that house. So looking at these settlements that we can see here, these are the geolocations for the girls that are enrolled in our program. Currently, we have a total of 7,000 girls that are living in this informal settlement, 10 to 14, 15 to 19, and 20 to 24 in those cohorts. So when we want, for example, to see what risk patterns or risk issues that are within a girl, say in this particular area, we will look around and scan through the girl roster mapping and know that there are hotspots, and there are also resources, community resources that this girl can access. Among the hotspots and things that are not, among the risk issues that the girl will face would be maybe there is in terms of the people that live around them, people that may waylay the girl on her way to school. There are also risk factors that include girls that, the drinking dens, where there is a lot of illicit brewing of illicit liquor, and the girl living around that particular household is expected to move from one area to the other to go to school. So we realize that the girl is exposed to a lot of risks. But within the same zones, we also know that there are community resources that the girl can access services through. For example, we have clinics, we have schools, we have we have commercial colleges that provide services to these girls. And within our program, we capture that so that we can advise and have safe spaces that will be able now to give an opportunity to the girls in our project. We have 11 of the safe spaces within our catchment zone, and in these 11 safe spaces, one of the service interventions that we provide is post-violence care interventions. And in post-violence care interventions, we are able to have two things. That we want the girls to access violence care through from the healthcare facilities, but we also want them to deal with historical violence that they've gone through, because the girls reported historically to have been violated. So we combine both clinical care and community care. So in this particular presentation, I'll focus on what we've done at their safe spaces, together with the trauma counselors and together with their mentors, because we have trained mentors that work with them in the safe spaces. A group therapy approach helps us to get the girls to be comfortable in a safe space for them to be able to speak and bring out their feelings, their emotions, their challenges, and what they feel is an inhibition based on the kind of violence that they went through. The trauma counselor is able to take them through psychologically through the phases of healing, and also how to ensure that they have accessed clinical care. And this allows the girls to really cultivate a lot of trust and confidence, first in themselves and also to the counselor and the clinical care setting that is near them. In terms of how the group therapy works, the girls are able to be emotionally stable, and they become aware about what and how to deal with the violence or the violation that they have been through, because it could be physical, it could be sexual, it could be emotional. Or sometimes it is a mix of all of these. Then the second step, after the girls have really become aware, the counselor takes them through cognitive and autonomy. And in this, the counselor has a number of sessions with the girls. And then they are able now to begin to take responsibility. They speak to each other. They are able to tell and encourage one another. And they actually want to take action. What we have seen transform them is the second phase, that they become quite aware, and now they want to step out and say, I went through this, and I want no other girl to go through this. I want to speak to the people in my area that violating girls, adolescent girls and young women is not good, and that girls need to be protected. So they really stand up to be like champions of preventing violence in the community level. We are looking at that and thinking that that's a big transformation, and most of the girls that have gone through this group therapy with our trauma counselors totals to up to about 2,552. And this shows that 95% of the girls that we've enrolled into our program have actually accessed counseling for physical violence. That is one which is, I think, the most reported. Intimate violence and sexual violence, I think, doesn't come out so automatic, but they still mention. But a majority of them, 95%, reported to have gone through physical violence. 5% said that they have they reported emotional violation, and the counselor has been able to deal with them in terms of how to cope with emotional trauma. We are looking at support groups within our project site that is covering the 7,000 girls. Currently, we have 43% of all the girls in groups. So for us, the group therapy approach is really easy, and it is able to get the girls to be comfortable to begin to deal with violence. And we are recommending that, we've learned that trauma counseling and support and information sharing for GBV-related matters is actually key for us if we have got to get the adolescent girls and young women transformed. We've also learned that adolescent girls and young women are exposed to GBV. If they're exposed to the prevention of GBV, there is an increased likelihood of them reporting the cases, as opposed to if we had never put them into groups, they will not come out and report. But if they have the information continuously with a counselor, they will be able to report this. We also have learned that multiple platforms for GBV prevention awareness is quite key, and so that we don't use a single approach. When the counselor at the clinical setting is talking about GBV prevention, we have the justice system, on the other hand, trying to follow up on the perpetrators. At the household and that community level, a group therapy will also help, and we are saying that a combination of all that brings in prevention. Post-GBV therapy groups have actually become an anchor for us for advocacy, and we are trying to create a network of girls that can come out collectively and say no to violence, and they are mobilizing people in Mukurupa Jenga slums in Nairobi so that there could be social justice for people that violated them. The girls that have come out through violation, we have seen them enroll into cookery classes, they do hairdressing, they do courses that would empower them economically, and we are happy as a program to report that these girls are actually taking life into their own hands, and they're saying that I want to move on. Even though I was violated, even this happened to me, but I think I have a life to live, and I want to avoid further risk by talking about violation to my peers. So we've seen a lot of transformation and successes with these girls. In conclusion, GBV is not a cup of coffee for everyone to talk about. It is quite hard for these girls and for anyone in our community to speak about violation, whether physical, whether sexual, whether emotional. It's not an easy subject. So even for us to have that therapy group work, the counselor has taken a lot of time with the girls, and they have had to create a lot of confidence for this to work. We also know that the GBV therapy sessions is a good platform, and we are recommending that if you need to start healing for the girls, for the program that you work for, let them speak as a group in peers and in the age-appropriate cohorts. For example, if they are 10 to 14 years old, make them to have a group of that particular group of girls. If they are 15 to 19, again, another group of that age cohort, and 20 to 24. They easily relate to each other in their age cohort. We have also seen that, we are concluding saying that the girls now have realized and recognized their role in mitigating and preventing violence. They are saying that I have a role. I want someone else besides me to do it. I want everyone to also become aware about this. And then, of course, the collective voice is much stronger than when one is crying. Thank you so much. I want to thank our donor, USAID Kenya, IMA World Health, and also, of course, all my team members that are in the room and back in Nairobi, and our adults, girls, and young women. Thank you.
Many thanks, Mary, for excellent presentation. Unfortunately, we are running out of time, so we will not take any questions, but we can interact with Mary at the end of the session. So I will now pass you on to my co-chair to introduce the rest of the presenters.
Okay, now we have next presenter is Mr. Ignatius Ulamogaba from Papua New Guinea. He's a medical doctor with a master in health management, over 19 years. Experience in clinical practice and public health programming includes technical and managerial roles in M&E and program management. Currently, he works for FHI 360 as Deputy Country Director in Papua New Guinea. Please, Doctor, your time is 15 minutes.
10 minutes.
10 minutes left? Oh, sorry.
Thank you, Chair. Good afternoon, everyone, and thank you for coming. So Papua New Guinea is probably the most populous nation or island in the Pacific region. Our HIV prevalence is actually under 1%, but when you begin to look at what is going on across the different regions in the country, you realize that some of the areas actually have prevalence as high as 1.68%. The prevalence is actually much higher in our key population groups, ranging from 14.9% in female sex workers and as high as 8.5% in the MSM and transgender groups. Our GBV record is probably very appalling. It's probably not the best. Most previous speakers have alluded to the fact that they see mostly around 1 in 3 women experiencing gender-based violence. But in Papua New Guinea, ours is 2 in every 3 women. And if you look at amongst the key population groups, it's as high as 41 to 45% reporting gender-based violence within the last 12 months. So for FHI 360, we are implementing a project called Strengthening HIV Services for Key Populations in PNG. This project is actually funded by PEFA through USAID. And one of our key objectives under that project is to increase access to GBV services, both facility-based and community-based services, especially for key populations. So our primary targets are the key population folks, but we also provide services to other high-risk groups as well as general populations. So prior to our interventions, what we noticed is that in Papua New Guinea, post-GBV clinical services were mainly offered by special clinics designated as family support centers. These family support centers are actually few in number. You don't have more than one in a province, and not all provinces actually have such facilities. And by design, these family support centers were basically focused on providing support to people who experience family-based violence. And so by default, somehow, key populations were excluded from that, and probably most likely because of the issues of discrimination and stigma. So they don't feel comfortable going to such clinics, and they're not even accessible to them in terms of proximity. So in our thoughts to see how we can make those services accessible to our primary target group, we thought that the way to go perhaps is to try to integrate these services into HIV and STI services that are already existing. So what did we exactly do? So we started our integration journey in 2015. And our initial interventions basically focus on preparing the service providers in the clinics to be able to provide quality, comprehensive, key population-friendly post-GBV clinical services. So we started from that, and then subsequently, when the clinics were ready to take on these clients, we now embark on extensive outreach services, focusing on raising awareness on GBV services, and also letting people know exactly where they can access these services. And then we try to make sure that we strengthen the referral linkages to ensure that people understand exactly where to go for these services. So the most important thing is that people who are rich in the community know exactly where to go for facility-based services and for other services apart from the health services such as shelter, law enforcement, and legal services. So what exactly did we do? So if you look at this slide, it actually tabulates the main interventions that we did under each of these components. So in terms of building the capacity of clinics, we focused on those 5 clinics that are being supported by the project. And why? Because these clinics already have adequate human resource. They've also been trained on most of the essential services as far as HIV is concerned. And then you also agree that there was already like an overlap between the skill set that is required to provide HIV and STI services and the skill sets that are required to provide post-GBV clinical care. So in a way, it was easy for us to do that. So that meant that we didn't have to spend resources and time having to train the service providers again on STI, management of STI, post-exposure prophylaxis, provider-initiated counseling and testing, and other areas. So we focused on what was lacking in terms of capacity. One of them was basically to build a capacity to be able to provide psychological support, psychological first aid. And then we actually adopted the screening protocol, which I think Manuela shared that in our presentation from WHO. So we actually built a capacity on how to apply that screening tool to identify people who must have experienced gender-based violence. The other thing we focus on doing is to really, really sensitize these clinic service providers so that they understand issues around sexual diversity and to be able to be sensitive to providing services to key populations. So other things that we did, I talked about the outreach awareness that we did. I talked about also building the capacity of the community workers. So we have the peer educators who are usually the first contacts with our peer educators, with our target populations. So these peer educators were now trained on how to effectively engage with their peers to make them understand what gender-based violence means, how it relates to HIV, the risks that comes with having going through gender-based violence, the risk that comes with being exposed to HIV. So once they had that, they also were able to talk to them and let them understand where they can actually access these post-GBV clinical services. So that done, now I would like to just share with you some of the results that we saw. In terms of the screening outcomes, you see that we started this intervention in 2015. So if you look at the, I think it's brown, unless I'm colorblind, but I think I see brown. So if you look at the brown bars actually tells us how many people that were being screened. And then the blue bars, not so many of them, some of them are really, really low, tells you how many people that were found to have experienced GBV in that screening process. What you see as the light blue lines gives you the proportion of those people who were identified to be survivors of gender-based violence. So what did we experience from this in terms of screening outcomes? So we realized that we were able to increase the number of people who were screened routinely for GBV services, for gender-based violence, from as little as 718 in 2015 to as high as 8,426 in 2017. This was really huge. And that tells you also that in terms of acceptability of the screening process, we didn't really have an issue with that, even though we can't give you exact figures, but I think the acceptability rate was really, really high. Unfortunately, if you look at the chart, I go back to it, if you look at the chart, you'll see that for 2015, you won't see any data telling you about what's happening in the key populations group, because then we had just started, so we were unable to disaggregate the data by Rick's group. But subsequently, we have that available. And you see that on the whole, the number of people screened increased, but the proportion of individuals who were identified as GBV survivors actually remained low. But however, if you look at the female sex workers group, you see that theirs was really high. There was that very marked increase from 2% to as high as 7% in FY 2017. Then in terms of uptake of services amongst those ones who are found to be survivors of GBV, so what did we find? So again, you see the brown bars or the orange bars basically represent those ones who were identified as having experienced gender-based violence, and includes all of those that were identified through the routine screening, as well as those ones who were referred from the community and from our peer educators. The blue bars, the deep blue bars, gives you an idea of how many of them actually access the required intervention based on the kind of violence that they experience. So again, you would see that there was a huge increase across all the groups. Now, what you see as a dip in 2015, it's basically more of data quality issue. What I mean by that is, at some point, 2 of the clinics had to be merged together because the government needed to establish a new clinic. So one of the clinics had to be demolished. So the staff in that clinic were moved to join the staff in the second clinic. And then it took a while before they could reassign roles and understand whose responsibility it is to document what. So that's what actually affected the dip that you see. So it's not like people were actually not taking up these services, but it was because the documentation was not adequate. So what did we realize from this component? We see that there was a marked increase in the proportion of survivors that were being seen, because all of the community-based awareness programs that were going on actually made people to be aware that services do exist. So we had lots of walk-in, and as well as people who were being identified from the routine screening. But again, you see that the increase was very remarkable amongst the key population groups. So in conclusion, what did we come up with at the end of all of this? We realized that integration of GBV services into HIV and STI services is quite feasible. And in our own case, we saw that this actually increased, because the increased access. Rather than people having to wait to go to the few family support centers, which are basically not even key population friendly. So they were able to now access these services in other 5 facilities that provide not just HIV and STI services, but have now been trained to provide this intervention for the post-GBV services. So we also realized that that proactive screening, you saw that from the data, proactive screening is not really giving us much. We're screening so many people, but the number of people that are identified as positive remains low, except for the female sex group. So that tells you that there may be other factors that actually affect disclosure. Okay, even when you prompt them, there are other factors, that very serious sociocultural factors in PNG that actually discourage survivors of GBV from actually disclosing their experience. And then we also realized that based on this, a combination of approaches will be required to actually improve the identification of survivors through this screening process. So what do we plan to do next? So what we have been doing so far is in the 5 clinics, and these 5 clinics basically have some kind of support, human resource support. But so what we want to do now is to scale up to additional sites. And our primary focus now is to look at those other sites that perhaps do not have additional HR support. We would like to see exactly how that plays out. But initial results that we're getting from that experiment shows some promising, it's quite promising. And we think that we'll probably record the same level of success that we're recording in the clinics that have additional human resource support. We recognize the fact that there's other factors that affect disclosure. So we would like to do further inquiries to understand what these factors are. And at this point, I would like to appreciate all of our partners, including the donors and the government partners who have worked with us in this process. I just want to share this picture. It's a picture I love very much. These are PNG men in Mary blouses. Mary blouses are basically the traditional blouses of the PNG women. So these men decided to wear these blouses, and then raised their hands to support the fight against gender-based violence. It was really nice, and it was part of the 16-day activism program. But what we are saying to them now is that it's not just enough to wear these many blouses. Be the man of honor, help us to stop that violence from your homes and also from your communities. Thank you for your time.
Our last speaker is Tatiana Musa Galifa from Kyrgyzstan. She's supervised studies on limited service and socio-psychological factor affecting HIV spread in IDUs women, and expert on GBV, preventing among women use drug, advocate for women use drug interest, and wrote clinical manual, management of pregnancy, childbirth, and postpartum period in women on psychoactive substance. Please, Ms. Tatiana.
Спасибо. Дамы и господа, позвольте представить вам модель Wings и результаты. Не работает? Может, вот с этой стороны. Где ваша презентация? Включите презентацию. Дамы и господа, позвольте представить вам модель Wings и результаты проекта «Крылья надежды». Оценка эффективности экспресс-вмешательства по профилактике гендерного насилия и интегрированные услуги по ВИЧ-консультированию и тестированию среди женщин, употребляющих наркотики.
Dear ladies and gentlemen, let me present you the WINGS model intervention and evaluating effects of integrating a brief gender-based violence prevention intervention with HIV counseling and testing among women who use drugs in the Kyrgyz Republic.
Мне хочется начать свое выступление со слов искренней признательности людям, живущим с ВИЧ, которые приняли участие в нашем проекте, нашли для этого время и смогли поделиться своим опытом и знаниями.
I want to begin my presentation by thanking the people living with HIV who participated in the project and generously shared their time, experience and knowledge.
Проект «Крылья надежды» ставил перед собой 3 цели.
The Wings of Hope project had 3 goals.
Адаптировать программу Wings,
First of all, we wanted to adopt the WINGS program,
которая совмещает процедуры скринирования, экспресс-вмешательства и перенаправления с целью выявления случаев гендерного насилия среди женщин, употребляющих наркотики, и тестирования на ВИЧ.
The WINGS model consists of an IPV screening, brief intervention, and referral to treatment service model.
Вторая цель – это провести пилотный проект, чтобы доказать эффективность модели, совмещающей рекомендации ВОЗ.
Second, we conducted a pilot trial to evaluate the effectiveness of the intervention integrated with the WHO recommendations.
Ну а также собрать статистику в электронном варианте.
And also we wanted to collect secure electronic data on frequency of all types of IPV and GBV.
И безопасным способом. Критерии отбора участниц проекта. В первую очередь участие должно быть добровольным.
The major eligibility criteria are as follows. First of all, the participants had to agree to participate.
Женщина могла участвовать в проекте, если она старше 18 лет.
A woman could participate in the project if she was 18 years or older.
Владеет русским языком.
If she could speak Russian.
Употребляет наркотики, либо имела опыт употребления наркотиков.
If she reported using illicit drugs in the past 3 months.
Либо находилась на лечении наркотической зависимости.
Or if she participated in some drug treatment program while participating in the project.
Социодемографический показатель участниц проекта составляет следующее. В общем, в проекте приняло участие 213 женщин.
On the slide you can see some socio-demographic characteristics of the participant. The total number of the participants was 213 women.
В возрасте от 18 до 60 лет.
The age was from 16 to 60 years.
Средний возрастной показатель 40 лет.
And the average age of our participants was 40 years old.
На этом слайде я хотела бы обратить ваше внимание на показателях семейного положения женщин, которые участвовали в проекте.
I would also like to draw your attention on this slide to the marital status of women who participated in the project.
Так, из всех, кто принял участие, из 213 женщин в гражданском браке состояли 32% участниц.
Out of all 230 women who participated in the project, 32% had a stable partner and were in common law marriage.
На момент участия в проекте разведенных было 22% участниц.
22% of the participants were divorced.
В официальном браке состояло 16% участниц.
And 16% of the participants were married.
Из всех принявших участие 72% имели детей.
Out of all the participants, 72% had children.
Из них у 55% дети были до 18 лет.
And 55% had underage children.
Также хотелось обратить ваше внимание на уровень образования участниц проекта.
I would also like to draw your attention to the education characteristics of the project participants.
Если вы посмотрите на слайд, то вы увидите 40% женщин, которые имеют только среднее образование.
If you take a look at the slide, you will see that 40% of the women had only secondary school education.
23% участниц имели среднеспециальное образование.
23% of the participants had vocational education.
И всего 7% участниц, которые закончили, имели высшее образование.
And only 7% of our participants had higher education.
Также обратите внимание, что 51% женщин предоставляли секс-услуги.
51% of our participants provided sex services.
На следующем слайде вы можете обратить внимание на все 7 этапов, ключевых этапов проекта «Крылья надежды».
On this slide, you can see the 7 key activities that we conducted in the frameworks of the project.
Первый этап – это приглашение к участию, скрининг, информированное согласие.
The first stage was recruitment, eligibility screening, and consenting.
Следующий этап, он очень основной, это базовое анкетирование.
The second intervention is like one of the basic interventions, and it was baseline assessment.
Цель которого выявление фактов насилия,
It intended to identify violence,
а также источников
the
насилия
perpetrators,
и частоты употребления наркотиков.
and frequency of drug use.
Следующий этап – это вмешательство в ВИНКС.
The next intervention is the WINGS intervention itself.
Далее следовало добровольное экспресс-тестирование на ВИЧ.
Then we had voluntary HIV rapid testing.
Второе занятие ВИНКС проводилось через 7-10 дней после первого занятия.
The second WINGS intervention took place after 7 to 10 days after the first intervention.
Далее проводилась участницами оценка проекта.
And then the participants themselves assessed the project and provided their survey.
И трехмесячное анкетирование, где мы наблюдали динамику, насколько этот проект действовал на женщин.
And in 3 months, we could see some trends and how effective this intervention was for the women who participated.
Ключевые компоненты вмешательства «Крылья надежды» — это вот первое и второе занятие.
The key components of the Wings of Hope project are the first and the second intervention. You can see the components on this slide.
Проводились с целью повышения осведомленности о разных типах насилия.
We wanted to raise awareness of women on different types of IPV and GBV.
И их взаимосвязи с рисками,
and how they are correlated with risks,
ассоциируемыми с употреблением наркотиков и заражением ВИЧ.
Which are associated with drug use and HIV.
Скринирование на различные типы гендерного насилия и насилия со стороны половых партнеров.
We also screened women for different types of IPV and GBV.
Мотивирование на решение проблем с насилием.
Motivated them to solve their problems that were related to IPV and GBV.
Работа над усилением социальной поддержки в случае насилия.
We wanted to enhance the social support that they could address in case of violence.
Составление плана безопасности.
And have a safety plan in place in case of emergency.
Постановка целей, направленных на снижение рисков насилия.
Women also set their goals in order to reduce and prevent violence.
Определение организаций, в которых женщина могла бы получить помощь.
And we tried to map the organizations that the woman could address in order to get help in case of violence.
И перенаправление к ним.
And refer women to these organizations.
А также мотивирование на решение проблем с ВИЧ.
We also motivated women to address their problems that were related to HIV.
Добровольное консультирование и тестирование на ВИЧ.
Get voluntary HIV testing and counseling.
С гендерно-специфичным консультированием.
Which included gender-specific counseling.
И курсом программ по профилактике.
And also we offered optional overdose prevention interventions.
Данный проект реализовывался в 2 городах Кыргызстана.
The project was implemented in 2 cities of the Kyrgyz Republic.
И в проекте приняло участие 6 организаций.
And 6 partner organizations took part in this project.
На слайде вы видите, какие наркотики употребляли женщины.
On this slide, you can see what type of drugs were used by our participants.
Когда женщина приходила в проект этот, она употребляла 45% из всех участников героина инъекционно.
When the women started this project, 45% of them injected heroin.
51% участниц употребляли седативные препараты.
51% of participants used sedatives.
И 17% употребляли опиум.
And 17% used opium.
Сводный анализ данных за 3 года показал, кто является основными источниками насилия.
The data that were accumulated in the 3 years of the project implementation showed who the major perpetrators were.
Так, 46% участниц определили, что насилие происходило со стороны супруга.
46% of participants identified spouse and partners as the major perpetrator.
15% участниц определили источник насилия со стороны милиции.
15% of the project participants talked about police violence.
Женщины, рассказывая о фактах насилия со стороны милиции,
when women were sharing their stories about police violence,
отмечали факты.
They mentioned the following experiences:
оскорбления,
insults,
вымогательство,
extortion,
незаконное задержание,
unlawful detention,
шантаж,
blackmailing,
избиение и злоупотребление полномочиями,
beating and abuse of power.
Со стороны тех,
and this experience came from those who were supposed to protect them.
Кто обязан защищать их права. Факты насилия женщины описывали как беспредел, раздевали догола, заставляли приседать голой, не давали пить.
In their stories, women used such descriptions as lawlessness, forced strip-off, forced me to sit up and down naked, refused to give drinking water.
Если мы посмотрим на распространенность насилия со стороны партнеров, то мы увидим, что женщины, принявшие участие в проекте, подвергались как гендерному насилию, так и со стороны половых партнеров.
We can see that women participants experienced both gender-based violence and intimate partner violence.
Это мужья, сожители, бывшие супруги.
From husbands, cohabitants and ex-spouses.
Наиболее частым было психологическое насилие, проявляющееся в оскорблениях и угрозах.
The most common type of violence was psychological abuse in the form of insults and threats.
Кроме того, женщины подвергались физическому насилию.
Women also reported that they experienced physical violence.
Избиением и применяли к ним насильственный секс.
They were beaten and forced to have sex even if they didn't want to.
Принуждали к оказанию сексуальных услуг.
Some were also forced to provide sexual services.
Также применяли другие виды насилия, как изоляция и запрет видеться с семьей.
Other types of violence that they were mentioning included isolation and preventing from seeing their families.
Если вы обратите внимание на красно-коричневую колонку, то вы увидите существенное снижение уровня виктимизации.
If you take a look at the red and brown column, you will see that the level of victimization successfully decreased during the project intervention.
Если мы посмотрим на распространенность насилия со стороны непартнеров женщин, то мы можем увидеть, что к ним применялись такие виды, как словесные оскорбления, угрозы.
If we take a look at the slide with violence that was from not intimate partners, we can see that severe physical abuse and verbal abuse were used against these women.
И посмотрим, насколько данный проект повлиял на женщин, как это насилие снизилось.
And we can see how this project affected the decrease of violence among these women.
В рамках проекта женщины получили перенаправление в те организации, где им могли бы предоставить квалифицированную помощь.
Under the project intervention, the women were referred to the organizations where they could receive help and support.
Если вы посмотрите, то увидите, что на 24% увеличилась обращаемость за услугами консультирования или образовательными программами равный равному по вопросу ВИЧ и ПП.
You can see from this slide that the uptake of service related to HIV peer-to-peer counseling and STD peer-to-peer counseling was increased by 23%.
На 15% увеличилась обращаемость за услугами консультантов или групп взаимопомощи.
The utilization of services related to counseling or group support to deal with partner abuse or other types of violence increased by 15%.
Уважаемые дамы и господа коллеги, из-за ограниченного, конечно, времени мы не можем предоставить вам все результаты этого проекта, но вы можете зайти на наш веб-сайт и посмотреть, если вас, конечно, это всех заинтересует. Спасибо за внимание.
Dear ladies and gentlemen, unfortunately the time constraints doesn't let us present all the impressive results that we had from this project. But if you are interested to learn any further information, please have a look at the websites that you can see on the slide here for more information. Thanks a lot for your attention.
Thank you thank you to all our presenters. And if you have any question, we're running out our time, so you can go to our excellent speaker to asking more deep or more detail about the intervention on GBV. Before we close this session, I would like to say that we cannot reach our goals to elimination new infection if we're not addressing gender-based violence and meaningful involvement of young people, adolescent girls, young women and boys in designing, planning, implementation and evaluation. Thank you.